Welcome to Week 8. We've covered study designs. Now we examine what can go wrong, the threats to validity that can lead us to incorrect conclusions. Bias and confounding are the enemies of valid inference. An association might exist between an exposure and outcome, but if that association is due to bias or confounding rather than a true effect, acting on it could harm patients. For healthcare managers, this session provides critical appraisal tools. When reading a study that claims an intervention works or a risk factor causes disease, you need to ask, could this finding be explained by bias or confounding? Before diving into bias, let's clarify what we mean by validity. Internal validity asks, are the study's conclusions true for the study population? Is the observed association real, or is it an artifact of how the study was conducted? External validity asks, do the findings apply to other populations? Can we generalize from this study's participants to our patients? Here's the key relationship: internal validity is prerequisite for external validity. If a study's findings aren't true for its own participants, they certainly aren't true for anyone else. A biased study is not generalizable no matter how representative its sample. Bias threatens internal validity. If an association exists only because of systematic error in how the study was conducted, acting on that association is misguided. For healthcare managers, both matter. You need studies that are internally valid, actually correct. And you need findings that apply to your population. But always assess internal validity first. Bias is systematic error, a consistent tendency to get the wrong answer. Unlike random error, which makes estimates imprecise but averages out, bias pushes estimates consistently in one direction. A biased bathroom scale might always read 5 pounds too low. More measurements won't help, you'll get precisely the wrong answer. Bias can operate in either direction. It might make an association appear stronger than it is, bias away from the null. Or it might make a real association appear weaker or disappear, bias toward the null. Critically, bias cannot be fixed by increasing sample size. If your study design systematically gets the wrong answer, studying more people just gives you more confidence in the wrong answer. This distinguishes bias from imprecision. A small study might get a correct but imprecise answer, wide confidence intervals. A biased study gets a wrong answer with potentially narrow confidence intervals. Recognizing bias requires understanding study methods. The statistics won't reveal it, the bias is baked into the data. Selection bias occurs when who gets into the study is related to both exposure and outcome. In case control studies, if cases and controls come from systematically different populations, exposure comparisons are invalid. Hospital cases compared to community controls might differ in healthcare-seeking behavior, not just the exposure of interest. Loss to follow-up in cohort studies creates selection bias if it's related to both exposure and outcome. If exposed people with early disease symptoms drop out, you underestimate the association. The healthy worker effect is a classic example. Workers are healthier than the general population because sick people don't work. Comparing worker mortality to general population mortality makes work look protective, even for dangerous jobs. Bergson's bias occurs in hospital-based studies. Hospital patients have multiple reasons for admission, creating spurious associations between conditions that both lead to hospitalization. For healthcare managers, selection bias means asking, who was studied? Who was missed? Are the studied participants representative, or systematically different? Information bias arises from errors in measuring exposure or outcome. Recall bias is classic in case control studies. Cases have been thinking about what caused their illness. They may remember exposures more thoroughly than healthy controls. Mothers of children with birth defects recall pregnancy exposures that mothers of healthy children forget. Interviewer bias occurs when interviewers probe differently based on disease status. An interviewer who knows someone has lung cancer might ask more persistently about smoking. Misclassification means putting people in wrong categories. If your smoking questionnaire isn't reliable, some smokers are classified as non-smokers and vice versa. Non-differential misclassification affects exposed and unexposed, or cases and controls, equally. It usually biases toward the null, making associations look weaker than they are. Differential misclassification affects groups differently. It can bias in either direction and is more dangerous because you can't predict its effect. Blinding reduces information bias. If outcome assessors don't know exposure status, they can't be biased by it. Confounding is perhaps the most important concept in observational epidemiology. A confounder is a third variable that is associated with both the exposure and the outcome, and is not on the causal pathway between them. Classic example: coffee drinking is associated with lung cancer. But coffee drinkers are more likely to smoke, and smoking causes lung cancer. Smoking confounds the coffee-cancer relationship. The apparent association is actually due to smoking. Confounding is different from bias. Bias is measurement error, getting the wrong numbers. Confounding is real data showing an association that's explained by another variable. Confounding can be addressed in study design through restriction, matching, or randomization. It can be addressed in analysis through stratification or multivariable adjustment. Randomization eliminates confounding by balancing all variables, measured and unmeasured, between groups. That's why RCTs are the gold standard. For healthcare managers, confounding means asking, what else differs between exposure groups that could explain the outcome? Observational associations may not be causal. You can address confounding in study design or analysis. Restriction limits the study to one level of the confounder. Study only non-smokers to eliminate smoking as a confounder. Simple but limits generalizability. Matching selects comparison groups with similar confounder values. Match each case with a control of same age and sex. Improves efficiency but requires matched analysis. Randomization, when feasible, eliminates confounding by balancing all factors. But it's only possible in experimental studies. Stratified analysis separates data by confounder levels and examines associations within strata. If the association disappears when you stratify by smoking, smoking was a confounder. Multivariable models like regression statistically adjust for multiple confounders simultaneously. Most epidemiologic papers use this approach. The critical limitation: you can only control what you measure. If an important confounder wasn't measured, you can't adjust for it. Residual confounding by unmeasured or poorly measured factors always remains possible in observational studies. This is why observational studies can't prove causation as definitively as RCTs. Let's summarize threats to validity. Bias is systematic error that cannot be fixed by larger samples. Selection bias affects who enters the study. Information bias affects how exposures and outcomes are measured. Recognize potential biases when critically appraising studies. Confounding occurs when a third variable explains an observed association. Unlike bias, confounding involves real data, the association exists but isn't causal. Observational studies can control for measured confounders through design and analysis, but cannot eliminate confounding by unmeasured factors. This fundamental limitation is why RCTs remain the gold standard for causal inference. When evaluating any study, ask 3 questions. Could this finding be due to bias? Could it be due to confounding? could it be due to chance? Only if you can rule out all three should you have confidence in a causal interpretation. For healthcare managers, these concepts are essential for evidence appraisal. Not all published associations are causal. Understanding bias and confounding helps you distinguish reliable findings from spurious ones. Next week, we build on this foundation to discuss causal inference more formally. See you next week.